Uh, Dear Pure Urology viewers, good evening, one and all. Today topic is Core Urology PCNL Bullseye Technique. As you all know, uh, many people use bullseye and triangulation techniques apart from ultrasound guided. In India, majority of the urologists use CM guided, in which bullseye and the triangulation are two methods. Today's speaker is Dr. Harprit Singh, who is very close friend from Jamshedpur to me. He has demonstrated many times bullseye, even in my own hospital 2 times in live workshop and also in many conferences, especially in inferior calyx and superior calyx is very accurate, and majority of the times it is bloodless, and very deep inferior calyxal stones also he can do that. I could witness many times. I thought uh, we will discuss with him today. That's why I requested Dr. Harpreet Singh a month back to give presentation on bullseye. Dr. Harpreet Singh is head of the Department of Urology, Mercy Hospital, Director, Eurovita Hospital, Jamshedpur. I think it's his own hospital now. Presented multiple papers in national, international meetings, demonstrated live surgeries in national conferences, numerous publications in national, international journals, written chapters in books. He is past honorary secretary, East Zone chapter, ex-council member of USI, member of endourology subspecialty of USI, and also he was the secretary honorary for that, national convener urolithiasis subsection of USI, so-called secretary, chairman scientific committee East Zone USI 2022-24, secretary urolithiasis, and also he is elect honorary secretary for USI, elect honorary treasurer for USI, if I am not wrong. With his good qualities, and he is a great human being, and very interested in stone surgery and teaching skills. So with this, I request Harpreet Singh to explain bullseye technique in detail. Harpreet, over to you, please.
Thank you, Chandramohan, for your kind words. Am I audible, Chandramohan?
Yes, very much audible.
Yeah, thank you for giving me this opportunity in your prime time. I say it's a prime time show which has a very long viewership, which you have started this program. I remember during the COVID or after the COVID, when the surgeries was not doing as a teaching program, which has now developed as a worldwide viewership. I think more than 8,000, if I recall. So thank you for your kind introduction. And like you, I'm interested in stonework, and I'm not at present secretary. I have put my papers for the treasurer, but that's a later thing. But thanks. And since there will be juniors, what I will do, I will just very quickly within few minutes, I will recapitulate the anatomy and then show you different cases. You can stop me and discuss it. It should not become a very bland presentation.
Okay.
Thank you once again, Chandramohan, for giving me this opportunity in pure urology.
Yeah.
So I have not disclosure. So this is just to tell you that what we are actually looking at is correct and suitable access, and it should be straight line. It may not be short. People say a short. No, it may not be short, but it should be straight line. We know this is a high flow system, and we should injure as less as possible. So this is just to give you the brief, just to show you how the anatomy works, how the anatomy looks. And orientation, Brodels and Hodgson type, Brodel more on the right and Hodgson left side. But with the present CT and scans and this era, now this I think is, I'm sure Chandramohan will admit, is no longer matter to us. But yes, knowing the anatomy is important. If you see the calycial orientation,
Harpreet, go little slow, no problem. There is no time bound here.
Okay.
Go little slow.
That's fine. Thanks, sir. I thought I'm little started late because of the...
No. Only 2 minutes you are late. There is no problem. There is no time bound. 1 hour you can take. But this will be lifetime presentation for the juniors. They can review again. So explain nicely, please.
Okay. So see, orientation is very important. The broader type is more on the right side, and the posterior calyces are lateral. Where the Hodgson type, the is more common on the left side, and the posterior calyces are medial. See, the percentages varies to both side can happen in both sides. Right side, broader can also open on the left side, and the Hodgson can also open on the right side. This is a basic orientation when we begin, and this the Campbell also tell it. But as you gain the experience, you will find that the now the decision factor is excretory urography or CT urography, which we do more and more. And if you see the calycial group, upper and lower poles are compound, and they project towards the polar regions. Only the middle calycial, you actually see middle part. There's an anterior and posterior. Otherwise, it is lateral and medial. And the lower pole generally have two or three calyx, and the one which is just lateral to the medial calyx is supposed to be the posterior calyx. And see, very important thing is that if you see the infundibulum, generally in 96% of time the upper pole has got single infundibulum, so it's much easier to come from upper, and lower pole have only single, only at the 46, less than 50% of time. So that way, if you can approach the upper pole is subcostal, it's very easy to come from above rather than going from below. Sometimes the lower pole calystrals anatomy is difficult. Once I will show you the cases, you will realize what I mean to say. Sempio has done a lot of things, you all know. Only two things I want to highlight. See, it is all about how the mid zone draining to the upper calyx or the lower pole. So 45% not crossed, good for us, but sometimes it is crossed. When it is crossed, you have to be very, very careful, whatever way, whether you do supine or you do a prone PCNL. You will, from here, from this calyx, you can go through this calyx and this infundibulum and to this calyx. You will not realize that. So this is very important to know the anatomy. And sometimes the major calyx open directly to the pelvis, and sometimes the minor calyx. This is just to give you the orientation. All this orientation you can see in the CT scan or you do in the retrograde pyelogram. And as I was telling that it has got 25% of the cardiac output, so very vascular. So when you're planning a puncture, it should come to this area, because this area you will have the least of the vessels. But see, we have a very large space to play around. This is the perfect. But if you come from this, if you come from this, then also it's good, as long as you are not going through this, because you see the vessels, this is disaster. If you're going through this area, it is disaster. So better to come from the cup is a large area. Even you see the bullseye shooting, with that we got a lot of prizes in the bull, Indians get, but this whole area is to play, so you don't feel that you have a very small field. I'll show you. Next important after bleeding is the chest complication. So supracostal punctures are very common. I do very often. You should know 12th rib. This is 12th rib. This is 11th, and this is 10th. And you see the lung is just near the 10th rib, and 11th rib and 12th rib. You see there's only pleura. So, and whenever you do supracostal punctures, you are actually all supracostal punctures come through diaphragm. So sometimes patients do complain of pain on that shoulder when you're even operating, if you're operating on a spinal anesthesia. So we can easily go between 12th and 11, 11 and 10, but above 10 is 50% chance of lung injury. There are ways and means to avoid, even you can come supracostal, but there are ways and means to avoid the injury to the lungs. So infracostal puncture should be made on the lower half of the intercostal space, not the upper half, because neurovascular bundle come from the upper half. This is one very important tip. Second thing, when you do under anesthesia, the tone of the abdominal wall disappear. Whether you do in spinal or GA, you will see, I'll show you, the kidney moves further careful. If you see the upper pole or the lower pole, which was below the subcostal rib, you will see above the subcostal. I'll show you in a minute. So decide your puncture accordingly, because infracostal may become supracostal. And retrorenal colon is 10% prone position. Fortunately, I have never got problem, but Chandramohan will be better able to tell. I see more and more fear in supine. In supine PCNL, those say the supine there is the least. I will not get into that controversy in this, because I am going to talk about bullseye today. So planning of the puncture you can do in CT, IVP. Do spend some time in CT and IVP, because when you're seeing the patient, that's the best time. You're at peace. Of course, retrograde parallelogram do help, but CT and IVP will give you the initial idea, because you're thinking about the rib, you're thinking about the anatomy. And so whenever you're deciding a puncture, how you decide? There are three factors which is very important. One, what is the relation to the 12th rib? See, this is a stone. So relation to the 12th rib, very important. Second, what is the hydronephrosis? What is the level of difficulty? This you should plan when you're pre-op planning. And third, is there any malrotation? Do you have to adjust your puncture or the technique when you're planning? Other factors, posterior calyx. Do I need to access to the upper calyx? Because if your stone is in the coming to the upper ureter, and what is the straight path? I have mentioned more and more. It is not the shortest path I am looking. I am looking which is the straight path, because I am avoiding the torque. And do I need single or multiple access or puncture? These two, three things are very important when you're deciding relation to 12th rib, hydronephrosis, animal rotation, and how you're going. What is the stone bulk? Is it going to the upper pole? So you have to decide your puncture. And if you find a dilated calyx, if it's a give a good access, you can think of that. So how to identify the posterior calyx in prone position fluoroscopy? We all know anterior calyx will be filled first because they are dependent. Posterior calyx will be contrast will be lighter because they are above. Air can be used, and posterior calyx will move opposite to the direction of CM. When you move the CM towards the surgeon, posterior calyx will move medially. I will show you when we will discuss our cases. So coming to bull's eye puncture is also known as the eye of the needle technique, because you see the tip of the needle. The target calyx is identified with the CM at 0 in the axial plane. So this is 0 degree. When you decide the calyx and you choose the calyx, you can keep it. This will give you the depth. And the puncture is made when the CM is rotated at 30 degree, and the calyx should appear like this. So 0 degree, you have decided the depth, that this is the medial, this is so far I will go, and the 30 is when you puncture, you will puncture in this axis, and you will make it 0 to see whether you have reached the calyx or not. There are other techniques I mentioned, by Chandramohan, triangulation, hybrid, gradual descent, you've gone. But actually, if you see, it's all the bullseye. Bull's eye is a biplanar. You pacify in one, you see in one, and you puncture in other. It's a very good technique, very safe technique, very easy, very reproducible. Don't need any calculation. Hybrid and bullseye, only difference is hybrid they do calculations, and what they do, they puncture in the 0 degree, whereas in bullseye you puncture in 30 degree. Otherwise, I don't see much difference. So I was mentioning that this is the when the CM is 0 degree, you have this is give you the medial aspect, and when you have rotated the CM towards you, and you see you have to make this bullseye. So how do you depth perception? See, green one is the right one. Green one is represent the, and red one, that means if you are going above, that means you are still superficial. And if the red blue one, you are going in deep. So you have to bring your needle, and this is the correct path. This is just to give you the depth perception. Now let's we come to the real time scenario. So this is a poor quality. This is a patient already came with a very poor IVP, so can't help. But this is a stone which is starting from the lower pole going to the pelvis, and there's one stone here, and you can see in the intravenous pallogram. This is it's a very undilated system in the lower pole. So if you see, this is ureteric catheter, and this is the stone, and this is in the prone position. You can see the stone. There is one more here which is not seen very clearly. So this fluoro orientation. Now see, this is the CM in the 0 degree. Patient is rare, and I'll show you once I will moving the CM towards 30 degree. See the movement of this calyx. See, it is moving medially, right? And then again, I'm coming back, then it become lateral. See again, this is very important. When you move towards yourself, it is going medial. And when you're coming back, it comes anterior, which I was telling. This is the identification of the posterior calyx. You may not find in every case. So when the CM is in 30 degree, this is 30 degree, and I made a bullseye. It is
Sorry,
not.
Harprit, I will stop here.
Yes.
In the lower calyx, when you have, in this case, there are two calyces I am seeing. You are agree, you agree?
Yeah, yeah,
Yeah.
absolutely correct. Go on, Chandramohan.
One above, one down.
Yeah,
In this case, you are telling that the above one is going medially. Is it correct,
yes.
or both will go medially?
Both will go, but you see the above, the below one is more lateral. As I shown the anatomy, then I told you the calyx just lateral to the medial calyx. If you have two, three calyx, that one is posterior as per the anatomy. And if I take you back, Chandramohan, just watch
Yeah.
this, realize what I mean. See, this is remaining here, but this calyx has moved medially,
Okay. Okay.
and
Okay.
then
Okay.
it will become zero. You see, it is again coming back later. This is the only
Sometimes
calyx.
you told that it doesn't move like that. Then how to
Yes,
identify that you will come later?
yes, I'll come later. I'll show you that also.
Okay. 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 Okay.
So this is the 0 degrees. Sometimes you will not get a tip all the time. Why you will not get it? Because see, we are using the needles all the time, so needles get little bent. But here you are able to see the tip, but you will not. And yes, saline drop will not come very nicely. But yes, I was in the system. But see, this is overshooting. So what you will do? You once you have made the you have punctured in end on calyx 30 degree. You have punctured, and when you made it straight, you see you have overshooted. So don't get panic. It can be two options. Either you have overshoot, you have bypassed, or you are just superficial. Just withdraw your needle and tell your assistant to push saline. And most of the times it is actually you have pushed little high, especially with the new needles. So just bring it here, and the saline come. You are in the system, and then you pass a guide wire. Watch this video and notice what is wrong with this video. Are you happy with the guide wire? The way the guide wire is going?
No. No. No.
No, this is outside. See,
Outside.
stone is here. When you see this sort of movement, that means you are not in. It looks like I'm in the pelvic calcial system. No, put contrast, confirm. This is very common. Oh my God, my guide wire is going. Sometimes it will just come parallel to the your ureter. You are
Yeah. Yeah.
not in. This is very important. Whenever when you see such a free movement, put contrast and check whether you're in the pelvic calcial system. So I'll show. So now see, when I try to pass, I'm not able to go beyond stone. I've taken new thermo. I tried all the maneuvers which I can try, but I'm not. So what I did, I made it 2, 3 rounds. So I left it there. Okay, let it be there so that even my assistant by mistake will still there are 1 or 2 coils are there. And now another thing. Now I always put 14 French Teflon dilator, not 14 French, 10 French Teflon dilator, which comes with the cook set. Just watch this. So what do you infer? You infer that this is moving with respiration. Once this is moving with respiration, that means you are in the kidney because I have removed this. After putting this, I was not sure whether I'm in it. I just checked it. It is moving. So I got sure. Other thing, you can push water. Then also you will take it. But I don't want to remove the guide wire. Don't want to take a chance. And I have dilated. I've not shown that part, but you can see the saline coming from below. So I'm always put saline and check before you dilating, because once you dilate it is dilated. So this is the first view. See, I'm just seeing the wall of the calyx. I have to adjust little and then I'm able to see the stone. I finish the whole stone and you see a small residue here. Chandraman, can you make a small
Yeah. Yeah.
residue?
Yeah. Yeah. Clearly, I can see that.
The small residue we tried to check. Again, we made a bullseye puncture. But now I asked my assistant to push water. It has come, but I'm not sure. So, what is the second thing I can do to make sure that I am in the system? Should I dilate or should not? Then just put saline and see if the saline is coming from this amplage. If a saline is coming from this amplage, that means you are in the system because it's a very small stone. Sometimes your catheter blood blocks, you have removed bulk of the stone, but this is also a test which gives you a confidence to persist with your puncture and do a puncture wash. So now after my puncture was, this is moved above. I just picked it up. I don't have the, this is the image. I picked it up and it's a complete trace. We're able to finish the stone.
Okay.
So bullseye, you have to make it medial by 0 degree, 30 at puncture, and you can go anywhere in this red spot. If you got this is perfect. So another case was Chandramohan has asked me one question. How will you know that it is a posterior calyx? It may not be posterior calyx, but if it gives me a straight line, it is going to that, I will happy with. I will not able to find a posterior calyx all the time. Posterior calyx generally you see when you have a in the middle part of the kidney, when the anterior posterior is very clearly defined. Polar we don't have all the time,
Yeah, yeah.
but again I'm telling one trick for the lower pole, the calyx in the lower porch, which is immediately closest to the ureter, is a medial one, is not posterior, but the one just lateral to that medial calyx is generally the posterior, and if you have three calyx, the second one is generally the middle one is again the posterior. So Chandramohan, I have this is very again the same thing, same blah blah, and I can do you notice anything, Chandramohan here? Can you notice anything in this image? Okay,
Uh,
it's not very clear. It's not your fault. So what I did, I put a air. You can see a air here. You can see a air here and air here. So I
mm.
was sure because I am in the system or not system. It's a posterior or not. So I put. You can see air accumulated here, air accumulated. So I got very confident that I'm in the right direction. So when you're not
How
sure,
often you inject air?
yeah, I use it very commonly when I'm not sure, especially.
Never had problem anything so far?
No, not a problem. Not a
Ah,
problem. Very good. Just put 10 cc. Whenever you have crowding of calyces, when you have very large number of calyces and you're very confused whether which one is the posterior calyx, put 10 cc here. It gives you a very good identification of the posterior. I'm a very big fan of it. But then your ureteric catheter also should be in the very right position. If it is too high in the upper calyx, you will not able to see. Keep it in the mid of the pelvis, and generally posterior calyces get identified, and you just push 10 cc. So here I have put air, so I got very sure that I'm in the right path, and I can see the stone also, and so I'm able to puncture this, and then it's just to give you that it is done. I want to here discuss one thing, that the movement of calyx with the CM, the same picture I was showing. See, this is a stone on the rib. I'm telling the for the junior six seniors, no problem. Most of the stone which you see is now come around 12th rib. This is a very small one, and you see this is the area of filling defect. It's a pelvis, and see this is the IVP, and you are below the 12th rib. But when you make the patient prone, that this same become 12th rib, and you can see this posterior calyx with the CM 30 degree. This has become medial. You can see that, and this is the lateral calyx and anterior calyx, which we say is actually lateral. So you can go. So this is just to identify when you turn the calyx, when the turn with the CM towards 30 degree, the calyx which moves away from you is the posterior calyx, and the one which is anterior calyx will be the lateral.
okay.
Just to show the armamentarium, this is not, you can do under anesthesia. I initially I used to do general anesthesia when I started, and supracostal generally sometime in the upper calyx difficult anatomy, or when I'm going to take a long time, I still do on the I still do GA. These are the old pictures. Then I use bolsters. But when I'm doing spinal anesthesia, generally I don't use bolsters. I use just padding below the knees, as well as there the ankle and the shin. I support, and the this is heavily supported. Otherwise, no need. This is just to give you revision if you miss anything. This is just medial marking. This is a stone, just a medial marking of the 0 degree. Then you come at just I'm revising 30 degree. I have turned. You see a bullseye, and when I thought that I have hit it, but when I was made it 0, I find that I'm still little behind. So again pushed a little, and you see it is little here. It looks like it is not end on, but actually when you do this, like it looks like not an end on, but when you make it 30 degree, you'll find end on pictures. Just a minute. So this is routine. There's nothing much. You can tackle any stone any way, whatever way you want to tie, whether it's radiolucent, whether it's bullseye is just a technique to get into the system. Biplanar mode, very soft, very easy, very reproducible, and sometimes you get this perfect picture of no splitting of papilla. You can try any, you can check your track, especially if you have a doubt whether you have gone through the colon. And this is a multiple stones. No longer it is nowadays we do. He has come with this. So I just want to make a point. Nothing against anybody or any technique. You can multi-puck. It is very rare nowadays. Generally, we don't do it, but you can do complete clearance with bullseye, and you can make as many as you like. Have to do it safely, no bleeding. At the end of the day, complete clearance, and you can achieve it. So awareness of the system is very important. You should know a bit of anatomy. Rest you will see. Always spend time on CT or excretory which you do. That 10 minutes very important when patient comes in. See the relationship with 12 thread. Whether my puncture will become supracostal or it I will remain subcostal, which is dilated, which is giving me straight line with it less of the talk. If you identify posterior calyx, it is not possible all the time. And supracostal puncture can be made infracostal by asking that taking the help of anesthetist or asking patient to take deep breath. We always do in anesthesia, and avoid puncture should be in the lower part of the rib. And don't also when you're going from the upper pole. I'm not able to put one slide. I wanted to show you the upper calyx puncture. Stay away from the mid scapular line, and colonic gas shot is also very helpful. And thank you very much. I'll stop here so that we can discuss. And should I stop share,
Yeah,
Chandramohan?
yeah,
And
stop
we
sharing. No problem. Yeah.
right.
So now let us discuss one by one. See, when you inject contrast with ureteric catheter into the PCS,
Yes.
will you slowly observe what's happening or it's not necessary? People say you only should inject or you should be constantly watching the CM with your footstep under your foot. Does it make any sense in bullseye that when contrast is going, the posterior calyx will be delineated as light and maybe later, so that we have to concentrate? Does it help? First question in bullseye.
Practical, very correct question, Chandramohan. Two things I want to see. When you see a stone, also see what is the density of the stone. We know from the Hounsfield unit also, and but how does it seen in the Siam is very important. Generally, we take the contrast under 50-50 dilution. But when I see a stone which is very light, which is not very well opacified in Siam, I further dilute my contrast. I ask my assistant to push it very slowly. I always keep the Siam pedal on myself. And however the calyces are filling, I watch that very, very careful. Which calyces are filling first, which calyces are filling later on, and what is the appearance. And sometimes if somebody has pushed very fast or somebody I'm not able to observe, I go back to CT scan and see what it is. Or if I'm still not sure about the calyx, then I use air pyelogram also to identify. But yes, do it slowly, do it gently, watch it, and you only have to watch, but teach your assistant to put slowly initially. Once you are sure about it, then you can ask them to put a little more, because sometime in the non-dilated system, contrast drains very fast. Before you can puncture it, it is drained. So, but just sure of the anatomy, do it fast.
Second question, whenever we put the ureteric catheter, it will be in the upper calyx. By forcibly you put it so that it will not slip. When
Correct.
the lower calyxial stone is there, you want to inject the air, you want to inject the dilute contrast, you will always adjust such that it is close to the stone infundibulum. Is it correct or not necessary? You will pull it down and do it?
Yeah, yes. Otherwise, if you, especially if you do a aeropylogram, it
Yeah.
takes it on the upper. If you put contrast, na, it takes time to fill the lower. The ideal thing is to keep it on the pelvis, but generally mid of the pelvis. What generally, but fear of that we are turning the patient, it should not slip out. Generally, we park in the upper calyx by habit. Correct.
Okay. Third question, when you inject the air pyelogram, when you aim it, uh, when you feel that you are in the proper position over the stone or over the calyx, when you remove it, do you see any air coming out of the calyx, or you will see the saline, or you will pass the guide wire. And second question in continuation of that, if you have partly missed the air and again repunctured, does the air in again putting air will help or not? I hope you are getting my point. One
I
is,
got your point.
yeah. First is air, whether it comes out through the needle. Second, third time, because every time you may not be successful in one attempt. So second, third time, will the air injection will be useful if it's already leaked through the guide wire? Already leaked through the needle.
Chandramohan, when you do it for the first time, the moment you will remove the stillet, you will see air coming out.
Hmm.
Moment you release, you see a little bit air coming out, and the saline starts coming
Yes.
because you tell your system. Second time, at times we try, but you are not sure about that air. Anna, you cannot be very confident. See how it had helped me sometimes. Sometimes what happened is extravasation has taken place by
Yeah.
my assistant had pushed very fast and vigorously. At that time, when you are fixed, it is all botch up contrast all over. At that time, putting 10 or 12 cc airs help you efficify the system. But the second part of the question which you have asked, that every time it is very difficult to say. You have to take, it may or may not be very difficult to. Then you have to rely on contrast. Moreover, if you see, when you have put air, now if you put contrast, generally what I see, the contrast doesn't come that good on that calyxes where the air has gone. It becomes rarefied.
Mohammed Rashid has asked a question. What is the difference between the bullseye and gradual descent? Is there any advantage? If as a, because I do not do bullseye, that's why I was keenly listening. In bullseye, you will go exactly the point where you wanted to go, because the same dot will continue. You cannot miss the dot. The only thing is, when you do with respiration or when any rib comes, you have to little bit cheat and then go in the same direction. Am I correct?
Yes, bull size, absolutely. So I take a lot of help from the patient. I told them to do take a respiration, and what I do, I make them do 2 3 times. So I keep my needle there. I ask them. I will not go in the front side, even if they, because sometimes they breathe more, sometimes they breathe less. So I check that what the optimum level he can bring his calyx down. When I check 2 3 times that this is the optimal level, I mark my point with the needle. Then I give them a minute rest, and then I take them to. By that time, I have stabbed my skin entry point, and I keep ready. And then I tell him to take a breathe, and then I got it entry. Gradual descent. They watch. They also do pipeline, but they don't come from the same point. They come more lateral, and then they puncture the align. So that is a
The
difference. But
gradual descent is part of the triangularization only. Uh,
part of the
see, in bullseye, first thing is, you are aiming the calyx in 0 and you are puncturing in 30.
yes.
What do they do in triangularization? We puncture in 0 and then check with 30. Generally, I
30.
do. I do. You have to, because you have seen in Nadiad both techniques. This point you should slowly discuss. You are still fast. It's only half an hour. It's a slowly you discuss. In bullseye, you tell, you put the needle on the target calyx in the 0 degree, and then you change to 30 degree. From the same entry point which you have decided, you go vertically down till the dot ends on the stone. Whether it is ending on the stone or not, you will be checking in 0 degree. You will be checking in 0 and you will be going deep or come out, deep or come out. But the checking is back to 0. So first point you decided entry point by 0, but while going in, you are going in 30 degree, because kidney is rotated 30 degree naturally. Whereas in triangularization, what we do, we keep a needle on the back of the patient. Approximately we select laterally one place. That is blind. That is blind. Then you insert the needle. You either can go descent, If you are more superficial, if you are afraid, go just below the skin, then keep on going down, gradually descend and reach the calyx in 30 degree. So 0 degree approximately you will puncture. This is approximation. Whereas in bullseye, there is no approximation. It is a scientific, exactly end on. Only problem is rib may come. And second problem I face is it is a straight track. If it is only posterior calyx, it is very good. After the posterior, if you wanted to go to the upper calyx, the tract will be little down into the calyx, then into the pelvis, then you have to go up into the upper calyx. That looks little, obliquity will not be there. Then the movement of the scope sometimes we feel is difficult because minimum tract vertical will be there in bullseye. Now slowly you comment on this.
Now you have summed it nice. See, uh, in let me first tell you the about the bullseye. Then
Yeah,
I'll come to second part of time. Bullseye, as you mentioned, we puncture in 30 degree, just end on, you just puncture. But to check the depth, you take the CM to 0 degree. You have to do only one movement for the depth perception, whether you have entered the calyx or not. You have to do 0 degree.
yeah,
So my job finished there. And if I am aligned, if I am depending upon the infundibulum, you can go till upper calyx. If lower calyx, you can do upper calyx, not a problem. From upper calyx also you can come from to below, is not a problem. That depends very anatomy to anatomy. You cannot fix that. But in triangulation, you have not only concern about the depth, you puncture in 0 degree, then you make check in 30 degree. You have also a concept of lateral and medial, which I don't have concern about lateral medial
yeah, yeah.
because going exactly you have to check lateral medial also and um,
Depth also.
but I have to check only one thing because I have gone 0, I have gone on 30 degree, I have checked that I have not crossed the calyx. As I shown you my first case that I have overcrossed. So I just pulled it, asked my assistant to pull. I know I'm in the system because I felt that I overshooted it. But at times I can be superficial also because that feeling of giveaway with come experience. You feel two giveaway. One when the muscle, because muscle 12, what happened with that the muscle memory is very good with the bullseye because you not give same time you're going to same muscle and puncturing and you're going and the second giveaway when you enter the calyx. But triangulation, I don't know. I feel that triangulation require more learning curve.
Siam you
As
see
my
also.
it
Triangulation
requires
is more Siam.
calculation.
But bullseye, they say that your hands will get little burned because you are I mean, just for discussion.
Yes,
Your hand also, some people use artery forceps to, uh, I mean,
yes. Sometime I also use when it takes time. See what happens, Chandramohan. Two things I feel is very difficult to puncture. My personal people may have different thought. One, when the kidney is very mobile, very difficult to puncture. Mobile kidney, it slips, you touch and go, touch, and generally it's very difficult. Second, when the patient takes lot of respiration, you need to fix the anxious patient, and if you're doing in spinal, you just have it becomes very difficult. This two, what is your experience?
yeah,
Which kid-
doing under spinal is very difficult. Honestly speaking, I am doing for last 20 years only under GA, and I have luxury that they will keep an apnea, and I'm really bothered with movements in either supine or prone. It is, uh, but majority of the Indians are doing under spinal very well, even with respiration, the way you are telling, because it saves minimum 5 to 8,000 rupees in spinal. If it is stagger, it may save around 10,000 also. Sometimes people will get that much profit only, honestly. That
correct.
entire profit will go. So this is a, Indians are very good, honestly, though no conflicts of interest in doing the under spinal with respiration, imagining, just stopping, just going. For the same Alken told that it is like tissue paper in the bathroom. plucking out. If you keep on pulling, it will come out. Suddenly, you have to do it so that it plucks out. That's one example. So you should be sharp enough where the loss of resistance is there and stop it there. Otherwise, you have shown our non-dilated systems. Actually, when I have seen you, even recently you did a bullseye in the inferior calyx. Which conference you did? Surat or where you have?
I done in stone. There were three stones. They're like three dots.
Yeah,
Absolutely radio.
it was very good. Actually, you more difficult cases you have done. You might have shown a much more better video where entire thing you might have shown. You have very
Next
good.
time I'll show a complete video. This time the video was not there,
Yeah,
but
yeah.
next I'll show
Video, I
complete
thought
video.
even I have your video, but I thought you will put it. I have your video. My conference video I have. So
Mr. Chandran, I ask you, what is your trick for mobile kidney? I want to listen from you, then I'll share mine also, but I want to know what you do for mobile kidney.
in case of spinal anesthesia, sometimes I do. When I have to counsel the patient that first, if you take less breathing, you will take more. If intelligent quotient is less, you have to show him going there, how deep inspiration, expiration is moving on the C-arm, how you have to stop it, where you have to stop it. 5 minutes pending, like you said, C-arm and CT, you read 5 minutes. Really, really correct. Same thing, you tell him that you okay, take it slowly, you have to talk slowly, he has to understand slowly, then you should be ready, like already skin is given, already rectus sheath, up to rectus sheath you go there, only that last 1 centimeter 2 centimeter of kidney parenchyma, in a least respiration inspiration, tuck you go. That is clinical skill. Nobody can teach on the video. That what exactly you said is correct. Go already, especially in muscular patients, it is very difficult because you can't move the needle. This is the only trick I have. Let me know from you.
So these are the people you will feel even in general anesthesia. They are as such, especially thin patient. They're very hypermobile kidneys. So what I do, though I don't put bolsters, I make a cotton ball, and I put that cotton ball below the abdomen part. So to make it stable, then the
Okay,
movement becomes little less. It is easier to puncture.
correct,
Just
correct.
sometimes I do that. It really helps.
Because your abdominal excursion you will reduce by
Yes.
putting tamper
Abdominal
it
extension.
on the
Just use abdominal.
uh,
Right word. Abdominal extension you want to reduce. It is the abdominal
so that the
extension
kidney
which.
doesn't move, and it will be, even if the patient takes respiration, it will not do that much. I want to
Correct.
ask one more question. I- See, in 100 cases where you do PCNL, you have the vast experience in 20 years. You are my contemporary. I think you and me are exactly
Correct.
finished MCH and went. So 20 years you are doing. How many cases you feel bullseye? You try all the first attempt bullseye only, I think. How many times you have to use a bit of triangulation? Was your training in Nadiad, which is Makkah of Indian urology, especially in PCNL, was your training both bullseye and triangulation at the time of your exit from MCH? And how do you adapt in a difficult situations? For example, supracostal, you have kept the entry point. Exactly below rib is there, center of the rib. Center of the rib. Then rib only will touch. Then what we do? We go little lateral, puncture it, and then triangularize. A little bit of bullseye and triangular, we will go inside. What is your opinion?
So Chandramohan, when I came from Nadiad, we were doing ultrasound guided puncture and fluoro adjustment.
Hmm.
And as you mentioned, Nadiad, we were doing freehand puncture. As you mentioned, 0 degree, 0 degree, 0 degree CM, and the free arm puncture just above the posterior axillary line, right? And then checking it there.
That means
So it takes.
triangulation only. That means practically triangular.
Correct, correct. So it took me some time because initially, when you learned on ultrasound, it was very difficult for me to
Yeah, yeah,
convert to flow.
yeah, yeah, yeah.
It took me some time that when I'm doing it, sometimes I'm succeeding in triangulation, sometimes not. Saying. Then I revised my technique. I converted to bull side and I found that it is more helpful to me. And coming to the 12th rib, as you mentioned, sometimes it does happen that you have to puncture the lower calyx. Also, I put a small ampulla and brought it down. If it is absolutely patient is not helping me to get in the 12th rib, sometimes lateral puncture, as mentioned by you. And only thing that keeping the tip of calyx, I many have times I have revised my puncture. Suppose I have puncture and I made it straight to 0 degree. I realize that I'm still not at exactly at the calyx. Leave aside cup. You always not, but even the calyx, it is all right. But sometimes we feel lateral. Just do another puncture, but that puncture, initial puncture will help you to get into the same tricks which you have mentioned. But taking help from the patient does help, and sometimes and anesthesia, अगर बहुत difficult है, use general anesthesia and take the help of a anesthetist to give a positive and expiratory pressure so that you can puncture the kidney.
Yeah.
Any
Now,
other trick you have in mind? You have something. I think there is something in your mind you wanted to share. Share it. We'll learn
no,
from you.
see, I when bullseye I do when triangulation fails. I am asking you, when your bullseye fails, will you use triangulation or you will be trying in bullseye?
Now, I do try. I do try Tamsam. See, nothing is fixed, and everything
Yes, exactly. I
doesn't work
want to
all the
listen
time.
from you. That's all.
Correct.
Exactly. So, uh, exactly, I wanted to listen that. Don't be have even if you have ultrasound, use it. Even if you try in bullseye, if it is not going, a little bit of lateral you go and adjust. Ultimately, the needle should be there on the calyx in two planes, and then the chances of success without injuring the infundibulum will be high. Some people like Harshavardhan does monoplanar, but it is purely body intuition that it is moving. I'm going, I'm hitting, that is purely perception. But ultimately, when you are not able to get the urine, you have to turn and see what exactly is happening. My last question to you: post operative, any cases or mal rotated cases or horseshoe kidney, anything, especially post pylolithotomy, some cases kidney will be little bit whatever you imagine, it may not be there. If you don't have ultrasound, what are the tips? This is a very less number of cases we will do, but I wanted to ask from you: mal rotated kidneys, horseshoe kidneys, post operative kidneys, not PCNL, post open surgeries, how do you assess is your 030 bullseye will do or not?
Chandraman, I am residing in an area which is not a metro.
Yeah,
So I still see a lot of open surgeries. I see things going bad. I do a lot of post-pylorothotomy surgeries.
yeah,
Only thing which I take care when I am doing a post pylorothotomy surgeries, and I'll tell you, I have broken one scope also.
yeah, yeah,
I'll tell you how. What is very important when the punctures to reach the kidney become very difficult because of massive fibrosis. So cut quite deep with a 12th knife. You tie the 11 number blade stab knife with the thread, because thread knife might open inside. Do it a very good puncture, because of fibrous tissue not a problem, and then puncture, and you have to really puncture with a good needle to reach the calyx. Bull's eye does very well. The bull's eye doesn't mean 30 degree. What bull's eye means, you rotate the C-arm as per the alignment of infundibulum, where infundibulum should be in a straight line. See, bull's eye is only about a straight line, not about the shortest line, may not be. But make it a very straight line, it will be. Same applies to horseshoe kidney. Initially, I remember, I'm talking of initial years. Initial years, see, we all know that horseshoe kidney, we come from superior calyx. But at times, stones are in a different calyx, and you really, because of that lot of accessory vessels, vascular anatomy is very different in the malformated kidney. You don't want to puncture lower calyces, but at times stones are there, and but then by practice, by experience, you learn you can puncture that calyx and also get away with that, with but keeping the same technique what I'm doing. So only thing you have to modify the angle of the CM. You cannot be always on 30 degree. That is what one message.
Okay. So with this, we conclude the session. 1 hour it is. Thank you very much. And more we will discuss in different case scenarios, some more case scenarios after 6 months. Thank you very much, Harprit. Nice presentation. You have passion in this. I understand. Thank you very much.
Thank you, Chandramohan, for giving me this opportunity. I hope that it must be a will be a learning experience for
Yeah,
our
yeah,
junior
definitely.
colleagues
For
who
today, a
wants to
lot
do.
of people, 165, more than that, the people have attended. Very nice.
Thanks.
Thank you.
Bye.